Maureen is in the first ever identified consumer role at the New South Wales Ministry of Health Centre for Alcohol and Other Drugs in the Alcohol and Other Drugs Values-Based Healthcare Program. Thank you, Maureen. Thank you. And Craig Worland is serving as the Manager of Lived Experience in Queensland Health, Mental Health, Alcohol and Other Drugs Strategy and Planning Branch. Thank you for joining us again, Craig. We have Tina Taylor, a proud Niampa Wawan woman, born on Wiradjuri country, Cowra, New South Wales, with over 10 years in the Aboriginal community-controlled sector. She has focused on improving health outcomes for Aboriginal communities. Tina led the social and emotional wellbeing team at Thurrowa Aboriginal Medical Service before becoming the first Aboriginal program coordinator at South West Sydney LHD, where she established a new Aboriginal drug health team. She now works as a Senior Engagement Officer at the Centre for Alcohol and Other Drugs, Ministry of Health, fostering partnerships between AMSs and LHDs, and she was also the co-chair of the Yarning Circle with Minister Park after the New South Wales Drug Summit. Now we have Stephanie Stevens. Stephanie is the Chief Operating Officer with Directions Health Services, one of Canberra and regional New South Wales' most experienced community organisations delivering programs and services for people impacted by alcohol and other drugs. Stephanie is heavily involved in a range of harm minimisation, health and treatment services, including NSPs, innovative service models, and implementation of CanTest, Australia's first fixed-site drug checking service. Thank you, Stephanie. Next we have Alison Churchill, AM, has worked as a social worker and counsellor with people criminalised populations and people who have been harmed by violence for over 30 years, both in England and Australia. For the past 25 years, Alison has been employed as the CEO of the Community Restorative Centre, CRC, a specialist organisation working to address the social determinants of incarceration and to assist support to people, increase their well-being and create pathways away from criminal legal systems.
Fancy.
And finally, Michael Woodhouse has been Executive Director in Health and Human Services for over 20 years, including in both government and not-for-profit sector. He has a strong interest in community-led services and programs, in better outcomes for Aboriginal and Torres Strait Islander people. Michael has experience in primary healthcare, disability, aged care, child and family services and inclusion strategies, and Michael has been involved in many LGBTQ+ community organisations, including as co-chair of the Sydney Gay and Lesbian Mardi Gras, and he was added to the Hall of Fame in 2023 and has been appointed as the CEO of ACON in 2023. 24. Awesome. Now let's get into the juicy questions. So this is a question for everyone, but I thought I might start with Craig and Maureen for the first question, if you don't mind.
No pressure.
So the first question is, and this is really the main question, how do we build a brighter and kinder future for people who use or have used drugs?
I've got my notes. Do you want me to go first?
Yes.
I mean, to state the obvious, and I think we know this, there's so much outside of drug use, the social determinants, health, all those other issues, poverty, education. Life's getting harder. You know, I'm 55 now, and just even the last 10 years, the evidence is in. Life is getting harder. The poor are getting poorer, the richer are getting richer, and all that has such an impact. And we wonder why people, you know, drink alcohol and take drugs. Well, life is so hard. But it's hard for us as workers to be able to address all those things, in our AOD space. So I suppose that's the first thought that comes to mind for me. But the other thing for me is we've been talking about stigma and discrimination for an awful long time. For me, it's been decades now. And I can't get over the fact that while something is against the law, it's natural to stigmatise against it. It's just logical. So how are we going to address stigma and discrimination until we get changes in the law? And to answer another question already, it was disappointing that the Drug Summit, you know, everyone in the room was asking about decriminalisation. And yeah, we just need to start having that conversation. Just start talking about it, because we are behind other places when it comes to those issues. What do you reckon?
Thanks, Maureen. And we will be getting to the Drug Summit as a question for panel members afterwards.
I have no notes, unlike Maureen, but I'm going to stand up and just show this shirt to everyone. I think it's going to start with this. This is the first time I've ever worn an activity type shirt. I'm feeling a bit nervous, so I'll just deal with it that way. How do we make it kinder? I'm someone who's probably anchored in, and in my role is around workforce. And today I want to reflect the answer to this question. I'm going to say that Rob did send it to us a few days ago, so I've been having it in the head. Is around bringing our workforce together and working together, no matter what discipline you're from, acknowledging, yes, I will anchor in the peer workforce and the AOD lived experiences to inform our services, work together. We have arrived into this workforce because of some of the support in the older days around from clinicians. And thank you. But now we're here, we want to work alongside you. And if I'm going to use some of the older 70s terms that I probably grew up around, is we want to give back. And we want to do that alongside you, and we want to put the client at the centre of what we're going to do. And I think until we can pull it together, we miss opportunities, and we have longer waiting lists and things like that for the people that are really reaching out to us at the absolute worst time of their life. For me, stigma was a self-stigma thing. It wasn't, I didn't give it, sorry, I won't swear again on stage.
You can.
So, didn't give two hoots about what anyone else thought. It was my own personal stigma. So I think for me, the kind of future is about pulling it together, putting that client at the core of every single thing that we do, and that creates a kinder future for people. So thank you.
Great, thanks, Craig. Who would like to go next?
Yeah, I'm happy to. I guess bouncing off things that both of you were saying. I mean, I work with criminalised people, and so an obvious response for the work that we do would be to say, let's shift the focus and the responses to drug and alcohol use away from a criminal intervention or criminal legislation to human rights and healthcare response, which would make a much happier and brighter future, I think, for many people. A lot of the legislation that we have at the moment in other places, different people would refer to it as necropolitics. It's legislation that actually leads to the incarceration and subsequent death of people, whether that's through drug poisoning or physical and mental ill health as a result of drug and alcohol use. So I think we should channel David Best, I decided, who was a bit of a key speaker for me today, in saying that let's put that recovery-centred approach to many of our systems across government, because we do know that people are using drugs because they're fun and they're a source of entertainment, but the people that often have harm caused by the use of drugs are, as you were saying, they're using them as a way to resist and cope with mental health, colonisation, domestic and family violence, and we need more supportive, caring, connected services in order to support all of us to have a brighter future.
Thanks so much, Alison.
Everyone's nodding at everyone.
It's so polite.
It's also agreeable. I'm happy to go next. I think it's already been covered, but harm minimisation and stigma are the two biggest pieces, I think. Outside of first ask them what will make for a bigger and a better and brighter future, because people will tell us and we should listen. What I hear is stigma and discrimination and harm minimisation are the things we need to address. You look in the ACT, and we've obviously had decrim for a little while. I heard some stats recently that despite 17% of an increase in police doing drug driving screening, there's been a reduction in people driving under the influence of drugs on the road. These are conversations that we need to be having in our services, with our funders. Even though we're tired of having these conversations, we've had summits, we've had inquiries, we've had commissions, we've had reports. It's us. We need to keep the conversations going and have the fodder to have those conversations. So please keep having them. In terms of harm minimisation, we need to, as service providers, take responsibility for having a harm minimisation approach, even if we are funded to be an abstinence-based program. You're going to work with people in every stage of change. So do your staff have something meaningful to offer someone, regardless of what drug they're using, what route of administration, what stage of change or crisis they might be in today, are they going to feel just as welcome in your service as if they're in maintenance or change? So working in the pre-contemplative stage with non-judgmental, with valued staff, I think is absolutely key. But also, obviously, innovative models like CanTest and drug checking, even though we're all getting a bit sick of talking about it being a good idea, I'm sure something similar happened with NSPs when they were established. But hopefully it'll become even more boring and normal, and we'll have more of it available.
Absolutely. Thank you very much, Stephanie. Tina or Michael?
Thanks, Michael. I don't know, I think going off the back of what everyone's saying up here, that whole, stigma and discrimination and the peer workforce and the Aboriginal workforce, I think sometimes the message gets lost what is actually needed in certain communities, and as you all know, different communities need different things, and I think it's going back to grassroots and finding out what's happening and like hearing from them, not through workers or through people who have their own agenda to kind of, lean it on the side of whatever they're, trying to advocate or work for. So my thing is we need to listen to the people who are accessing our services or not accessing our services. It's getting that genuine feedback. I remember when I was in the district, they needed to do some feedback on a clinic we were running, and one of the workers was like, oh no, they're not really, and it was just very basic borderline stuff, and I was like, you know what, I'm just going to give them a call myself. And I'm like, look, I kind of manage this program, but if you don't tell me why you're not coming, you have to tell me why you're not coming back, but tell me about your experience so the next person who accesses this clinic will have a better experience than you have. And then they were just so open and honest and like, well, you know what, having to fill out the form in reception so people know where I'm going, I don't want that. And I was like, beautiful feedback, let's switch it up. So, I just think getting to the grassroots of the people accessing our services.
Thanks, Tina. And the people not coming in, I think that's really great, that we really need to understand who's not coming into our services and why.
I guess my sense is I really enjoyed this morning's presentations and just trying to draw together a couple of those threads. Tracy's presentation of herself as an eternal optimist, I think, is perhaps a pledge that many of us can take, that actually we can do great work here, and part of creating a brighter and kinder future in this sector for people who use drugs is also holding on to our own hope and optimism. Equally, I was really interested in Professor Best's work around how is it you involve involve the whole community? How is it that we actually make it possible to be having a conversation about, be it recovery or harm minimisation or the whole range of issues that we are all working with as a sector? I think if I was to try to boil it down and possibly oversimplify, it feels to me like part of our role here is how do we talk about people who use drugs as whole people? People with strengths, people with lives, people with names, that actually humanises the experience of the people that we all work with for our own practice, in our broader organisations, in the communities in which we mix. I'm really interested. So work at ACON, we see quite a lot of data around various experiences of stigma across the different communities in which we work. And that data tells us that particularly stigma faced by people who inject drugs is significantly higher than the stigma faced by, for example, gay men. Yeah? I suspect part of that is, as a community, we've been on a journey about people hearing and experiencing the full lives of gay and lesbian people in our community in a way that feels much more real for the entire community. And perhaps that's the upside of the marriage equality debate or some of those those works. That's perhaps the path that we might have here as well. How is it that we try and tell stories about the full lives, the strengths, the wonderful contribution of the people that we work with, of people who use drugs, to our community, to our organisations, to our society.
Thanks, Michael. And I think you can clap. I know we all work in particular roles as well, but I think, it would be really useful to think about, who are the players outside of there that we need to work with as well to make things change? I know media's often politicians and so on, but as we reflect on some of these questions, it'd be great to think about who are the other people we need to be talking to that we may not be talking to. So thank you for reflecting on how we build a brighter and kinder future for people who use drugs, but we have a big audience here of workers. How do we build a brighter and kinder future for our workers, the workers who are creating the brighter and kinder future for the people coming into our services?
Thinking of people who aren't only in the room, around the stability of our funding contracts to help the workforce to feel valued and know that they will be here for the long term and their positions will be sustained, I think is a really important thing to note. And I know it's come up heavily in the Drug Summit and elsewhere, so it's good to have it acknowledged. But I think some of the good work that's gone into establishing the core competencies being offered for free in New South Wales is a wonderful thing. We've had additional funding into the AOD space in the last few years, so there's workforce here that didn't exist previously who've come in from other areas with amazing qualifications and experience, and so we've needed to kind of bring them into the great space that is AOD. I think too there's something about workplace culture that we don't always get right, and I'm not saying it's perfect where I'm from, but our corporate services and our organisations exist to support our staff to deliver the programs, because without them there's no point. So I think having an ethos and a culture wherein the work that the frontline workers do is incredibly valued, I think is what really sits behind it, and it helps to address some of the stigma that people have talked about today. Uni of New South Wales and I know ATODA, the ACT Peak, are looking at the stigmatisation of us as the workforce. So I think us being mindful of that and service managers being mindful of that from a wellbeing perspective, and then also being sure that we advocate for and allocate enough funding for wellbeing initiatives and training and supervision and all of those key kind of supports, in addition to preserving, the psychological safety and the pressures that just exist in the day-to-day of such challenging work. I think a current thing too is really how do we work with, established peer roles in a way now that perhaps we had lived experience but maybe less identified peer roles, and how do we do that in a way that really maximises and respects and values that contribution when it's titled as opposed to maybe implied or personally owned. So I think we also have a bit of work to do there.
Absolutely. Maureen?
Lots to say. I mean, first of all, we've got to recognise that 80% of the people working in AOD have got lived experience. It certainly feels like it's 80% of you. But, it's not you can't. It'd just be great if you could acknowledge that and talk about it. I've seen it work so well. If a doctor can, once I saw, I shouldn't be disclosing someone else's story, I suppose, but he just said, when I was in uni, I was in the tavern way too much. And, this guy who used crystal meth, he just grabbed hold of that story and he was like, really, did you? Oh, you naughty person. And it was just that connection, of, other people, we all have issues. And it'd just be great if we could tell our own stories when appropriate as workers, even if you're not in a lived experience position. But the other thing I actually wanted to spend time talking about this yesterday is all the barriers to being a lived and living experience worker. There are so many barriers, just starting with police checks. Mm-hmm. So, you got a police record for 10 years. I was talking to a woman just last week who said, I've given up. So I went for a job and they pretty much said to me, you've got a record, that person hasn't. It's just too much work even trying to negotiate and, deal with you. They were really bluntly honest with her. Until you can make that record go away, it's going to be really, very hard for you to get an employment. And there's other things like qualifications, there's Cert 4 in peer work, there's a Cert 4 in mental health, but there's not Cert 4 in mental health peer work, but there's not the equivalent in AOD peer work. But a lot of jobs demand you have a Cert 4. There's just so many barriers to people, joining the lived and living experience workforce. Managers don't know how to negotiate reasonable adjustments. For example, I do 32 hours a week, but I only do a 6-hour day over 5 days. That's really worked for me. And you need to be able to negotiate those kind of adjustments with your manager. And if they've got no experience in managing a peer worker, because they're a clinician, it's not their fault either. Everyone's sort of set up to fail. So there needs to be a lot more support for the LLE workforce. Stop now.
Thanks, Maureen.
lead on to that because I wrote a little note as you were talking. I was like, I don't remember. I'm perspirating up here. It's quite nervous. With the whole qualification thing, you got me thinking about mob that are going into, well, like let's go back to PDs. Like some services need to really calm down on what they're asking for in a PD because you're scaring us away. They're like, no way am I applying for that, and you're losing really good people because you're making this job sound impossible. Even if it's just plain language. Or, you know, a day-to-day, like at Southwest Local Health District, we've really modified the way we advertise jobs and, you know, even the Aboriginal Workforce Manager calling people directly saying that, you know, I've seen you had a look at this job, let me explain a few things that are happening, like kind of almost coaxing them into the workforce, but you got to do what you got to do, we need people. But with the qualifications, I was thinking very similar in our Aboriginal health workforce, that we come with cultural knowledge that you don't get a piece of paper for, you know, and like we, especially for our mob that are still practicing their culture and, you know, trying to really delve in or reconnecting with it, that needs to be a part of the workforce kind of, you know, if you get study leave, you know, I suppose you just got to account for, you've employed us because we're Aboriginal, because of our connection to community, but you're going to keep us in an office? Like, how am I meant to connect? Because once you kind of are away from community, they're like, oh no, she, you know, that one. And it's not the first time, they don't say about me because I'm always out. But, but we've all heard people go, oh yeah, they went over there, they're too good for us now. And they, you know, and it's really just because they're super busy doing that whole list that was on the PD that they got. But yeah, I think that cultural knowledge needs to be kind of how that works. Don't know. We were trying to figure that out in the district that I was previously in, because there's just no piece of paper that attaches to cultural knowledge. And I think one thing that our workforce need to do, I think I might have went off a little script. I didn't think I was going to talk at all, but here we go. You'll start calling me Annie Malcolm or Susie Hudson in a second, because no, not because of the talking, because I'm about to reference the clinical care standards. That's why. I think with the work that they've been doing in that, because when I got to drug health services, I was kind of like, but why do we do it like that? And like the question I kept getting was, because that's how we've always done it. And it's like, no. And I think them clinical care standards really show you a way to revoice how we're all doing the same thing. We're not learnt by that, you know, nurse that's been around a little bit too long and really needs to move on, who, you know, did one respecting the difference course 20 years ago. Well, you've got to do it every 8 years now, it's a new policy. But yeah, I think relearning and changing what we do and actually fighting against the norm, I suppose. So advocating for each other, and if you can't do it, call me. I'll try.
You might be busy. Any other speakers want to make a comment about building a brighter kind of future for our workforce?
It might be a bit of a segue, but how about we fund that unmet need?
Yeah.
Actually growing the sector, it strikes me as a really interesting thing in this sector. There are more people looking for various forms of assistance than we all have capacity to provide. That puts pressure on all of our systems, our organisations and our workforce.
Absolutely.
And that seems like a pretty obvious place to start.
Definitely.
And the psychiatrists, it worries me that we've had a mass walkout of our psychiatrists, and, you know, we need to make sure that we're not sort of co-opted as allied health workers. I'm not a psychiatrist, obviously, and yeah, I don't know what else to say about that, but it's a concern. We need to take care of everyone, don't we?
Well, we could have asked Minister Jackson, but unfortunately she can't be here today. The next question that I've got is about harm. So we've talked about reducing harm. So how do we make sure that we reduce harms to all people? And by that I mean, you know, different population groups, and also across, you know, New South Wales is a huge area to cover. And I think the Special Commission has definitely expanded access. But how do we make sure that we reduce harms to all people, different populations and regional rural communities?
Look, happy to jump in quickly. I think certainly we know within the LGBTQ plus community that what people are looking for is choice. That actually a service system that gives people the choice as to whether or not they might seek services from within a queer organisation or a mainstream organisation, and that all of that be of an equivalent standard and allows people to receive a service that meets them where they're at. I'm not sure we've necessarily, I think one of the great opportunities, let me put it the other way, one of the great opportunities of trying to do a proper 10-year plan and some good drug policy in New South Wales would be to think about, well, what is the network of service providers that we want to create? Where are the places where we can increase choice so that actually people can be met wherever they want to be at? Yeah, we can meet them where their need is, where their interest is at that point in time. And I think that would go a long way to ensuring that we address some of those access gaps so that the system is organised around the diversity of the people who need support, not people trying to fit themselves into a system that wasn't designed for them.
That's great. And yes, I think we do hope that when we do have a drug and alcohol strategy in New South Wales, that there is some vision and that we actually think long term about what is the system we want in 10 years' time.
I have one to go wide on this.
Yeah,
right?
please.
And I think it's around potential psychological harms for two sides of a fence. One being people accessing treatment and they go home after that. And also the people that are chosen family, kin, whatever you want, your loved ones, working with them a bit deeper. So when people are accessing treatment, and I've seen this a million times amongst my friends, they go home and their partner or mumsy says, right, are you over that? And are you ready to make it up to us? And that folds out to, let's go straight back down the scale to where we started from because I'm not ready for that. So I think when we have treatment and do that with people, let's not forget that next circle around them and work with them because that's the landing platform for when people come out of treatment and everything. It's not, they don't have a counsellor sitting there with them or a peer worker when they get home. That's the dialogue that begins there. So I did go wide and call it harms, but it potentially is. And I think that's something we just don't land very well.
Yeah, I think it's a great point. And I think, the family and carer grants that went out to the sector through the Special Commission was so oversubscribed. There's such a need to continue to support families at different layers as well. I know, the issues that you're talking about, there's a few things to unpack there, but just more broadly in terms of thinking about families and communities and how we work.
Yeah, one of the rehabs I've worked with years and years ago had loved one night where they just come in and they spend some time with everyone. Then all the people in the rehab go and have dinner, but then this bunch of mums and dads and brothers and loved ones and all that stuff have their own little dinner and they become a bit of a support network, so that's great.
Nice.
I think we definitely need a service system that is more accessible, certainly in regional areas and remote areas, but also right across the Greater Sydney Met region. There's certain areas where it's very difficult to come forward to ask for support without being surveilled or monitored or having the fear of sort of legal ramifications as a result of that. And whilst that continues, being able to deliver an equitable sort of model of care is going to be really, really difficult. Certainly in regional areas, and I know that's a question later, but it's, accessing a service, it's really difficult if there is one, but if you are knocking on the door of a health service, then everybody knows what you're there for. And so many Aboriginal communities, they stay at home and there's nothing equitable about that. But also, even when we're talking about some of the wins or the recommendations out of the drug summit, one of the recommendations about pill testing, absolutely support that 100%. But it'd be amazing if we could actually deliver a more equitable system of that and actually have drug testing, right across the state. So it's not, it's totally available for everybody. and when we are tangled up in the criminal legal system, and then why don't we have some sort of increase some diversion options pre-sentence rather than only providing treatment at the back end? Let's actually see if we can get some equitable care for people before they're convicted of offences. I think, and I know I'm going to harp on all the way through this around the need to decriminalise or regulate, but I honestly don't know how you can implement a equal system, which ultimately needs to be a healthcare system along with addressing other forms of disadvantage, whilst we continue to define this particular activity as illegal, certainly illicit drug use. I think I remain optimistic. I've been a CRC for way over 2 decades. I am in there for the long haul, and have hope. But I do think you just can't go past that conversation. It's the baseline, the foundation for nearly everything, including workers' remuneration and all of those things. It's foundational to most of the issues that we talk about.
We're mopping up additional harms because of those legal penalties in the meantime, and can't shift the stigma. And sadly, there are models where drug checking has worked in regional places overseas where outreach models can work, but we can't even get that right for NSPs. I was chatting to one of our regional managers at lunch who was saying that the vending machines at the local LHD were empty for 4 days over Christmas, and it was only because of our loud advocacy that they got refilled. And it took, I think, close to 2 years for us to become an NGO NSP provider in New South Wales.
Right.
We'd desperately like to do more of that too, but sadly things have moved really slowly, and it'd be good to have more appetite to take the wins where we can get them more easily.
Can I add?
Yeah,
it seems crazy to me if you're going to have drug checking at a festival and then you've got police doing searches over there. And until we think about and convince police to relook at the way they do things, there is this fantastic organisation that Nick Crofts runs, the Public Health Association, Public Health Policing Australia, they're called, I think. And it's all about a public health kind of approach to policing, doing all this sort of obvious stuff instead of, strip searching a young person and traumatising them. Why don't you help them instead? So if they're off their chops and they need help, go over and help them. Take them home. Don't arrest them and strip search them. It'd be great but I just can't see our police in New South Wales ever, reorientating the way. And in rural areas. Hopeful. And you hear these horror stories of rural areas. You get known by the police once and then they're after you from then on. You don't know, and you'll get pulled over as soon as you step outside your house if you've got a record, and that's it for you. And there are changes in regional areas, like telehealth is great, but I don't think we should put all our eggs into the telehealth basket either. We've always got to have lots of options. There are other good stuff. At the Drug Summit, there is more youth diversion, which is great, but we just need more and more of this stuff. And diversion shouldn't be. It should be mandatory, not discretionary. When police have got a choice about it, bad things happen.
So I think we've naturally moved on to the final question,
Sorry.
which is about the Drug Summit, but not just about the Drug Summit. So we have 2 levels of government that really guide what happens in terms of drug policy in Australia. We did have a Drug Summit. A report's been handed down. We're waiting for the New South Wales government to respond. So I'm keen to hear all your views, and you've already started to, but naturally for that to come out. But we did also have an inquiry into the impact of alcohol and other drugs at the federal level as well. An election did put a pause on that. They did push an issues paper out, and one of the recommendations is for that inquiry to continue. So we have 2 levels of government, an interest in alcohol and other drugs. I'm cautious to say priority, just because we know there are different things that guide our government. So I'm really interested to hear your views, and I did tell Tina I'm going to start with her. For those that went to the Drug Summit, there were some population groups that weren't happy with how they were represented, their ability to speak about what the views were impacting on themselves. So Tina, you co-chaired a yarning circle with Minister Park, and many of us didn't get to hear, if you haven't read the report, Are you able to tell us a little bit about how those yarning circles went and what your thoughts are on those?
Well, I don't have a choice. I'm sitting here, but yeah.
You always have a choice.
Yes. The yarning circle, that was like such a lot happening in such a short time. So out of the drug summit, Minister Park reached out to Michael Doyle and said, like, let's do this. So we started a little working group. Some people are in the room here now, and talked about, what are the key things we want to discuss, like for our people. Then we had this massive list of these are the people that should be coming, and a lot of the people have never really had a seat at the table. That's the ones that we wanted there. What else happened? So it was on the 6th of Feb, so we went through like the Christmas holiday, so there was like 6 weeks to plan this, and most of us were away for 2. Some of us were logging on, I think Rach is in the room, logging on from holiday, like on their laptop to these meetings to get together. We had a lot of support from Daniel Manadou and the team at Centre of Alcohol and Other Drugs, giving us secretariat support, literally letting me just work on the yarning circle for 6 weeks. And I did write down the key headings because I didn't want to get it wrong. So the yarning circle addressed 4 key topics, which really, because we had this whole big list of topics and a lot of them just fell underneath. But cultural approaches to working in AOD. So we talked about kind of cultural mapping at an assessment point. The stuff I was talking about earlier, like bringing cultural knowledge into what you do, but also, the safety of our workforce. Infrastructure to support the AOD workforce. I think I just got that muddled up, but you got the idea. Supporting parents who use AOD, and that was a very, I think Kathy Sheridan from Wee Jelly, she would help. We had yarn leaders leading that, so they came with points, and then I'll tell you the last one, sorry. Treatment and diversion is the last one. So the way the day kind of rolled out is, I think there was about 37 people there, and I think about 6 were not Aboriginal, and that was really different for all the Aboriginal people in the room. Were like, oh, now you know how it feels. Look at that. So it was like really highlighting, and like I remember seeing, Uncle Al from Wee Jelly and Ty from Legal Aid, both Bree boys, and just like they hugged in the middle of the circle because they hadn't seen each other for a while, and I thought, how beautiful is this? Because generally we get together at funerals, court sentencings or knockout. But so it was just really, it was such a beautiful experience, and I co-chaired with Michael Doyle. It was really good because I hadn't really worked with Michael too much prior to that, so me and him have a newfound friendship. It was some really robust conversations, very heated discussions, so you can read more. We wrote a report after it to kind of sum up, so then everyone knew what was happening. But yeah, that was...
So what's your hope then coming out of next steps?
I've got a lot of hopes, I think. I think some of the stuff in there was around, Aboriginal leadership, and I suppose that whole you can't be what you can't see. Just Aboriginal people having a seat at the table for genuine, not tokenistic, just genuine, like we're here to listen and tell us what to do. And a lot, I think in a session yesterday, we were kind of discussing that, we're all for self-determination, but also we need to stop, blaming everyone else for things aren't happening. Like we're in jobs that were never existed before, and this is our chance to kind of fight for what's right and not be that person who's sitting in this same room 10 years from now going, we've been talking about this, because coming up in my career, I'd be sitting next to people going, we talked about this 20 years ago, and I don't want to be saying that in 10 years' time when I'm an elder.
So, drug policy in New South Wales, what are your views? Yeah, Alison.
Well, Drug Summit.
Yes.
I don't oppose the 56 recommendations, but I guess I'm unapologetically pissed off with a lot of the framing of the summit report. I think, as you pointed out, Tina, we know the voices and they've been quite clearly articulated, and people have tried to play catch up to talk to some of the voices that weren't in the room and have been identified as not being in the room. But the voices of the people that we work alongside with at CRC don't appear to have been raised as a particular group that might be worthy of speaking to. We've got 10,000 people that are incarcerated, over 10,000 people that are incarcerated in our prisons. Every year, 20,000 people cycling through. They're literally a captive audience. People could have gone in. They're at the pointy end of the drug and alcohol laws, and there was zero consultation or particular concern that they weren't consulted, and I think that's a tragedy. And a huge missed opportunity, one that could still be caught up on, however, like we can have the groups afterwards, let's not say it's done. But, on top of that, we've got, for every one person that's incarcerated, there's an estimated 5 other people, family and kin, that might be negatively impacted. Some people might be safer, but other people could be negatively impacted, and that cycle of, disadvantage and harm that can be caused as a result of incarceration hasn't been captured at all. And, to our shame, we're incarcerating First Nations people at a higher level than any other country in the world, and particularly our women. And we weren't talking to that group, and we still haven't spoken to that group, nor, equally as importantly, Australia is a signatory to the UN standard rules on the treatment of prisoners, referred to as the Mandela rules, that basically suggest that people in prison should be afforded the same level of healthcare as people in the community. Didn't raise its head within the drug summit. It is far from equal. That's not a criticism of Justice Health or any particular body, but their treatment, they don't have access to safe injecting equipment, to cleaning drug equipment or injecting equipment. They don't have access to AOD counselling. It's limited options in relation to OTP. And then we know there's perpetual sort of problems when they come out of custody, completely omitted from any of the conversations. And on top of that, it was like being in an echo chamber around, at the drug summit, with the voices overtly and covertly rumbling in the corridors about the need for decriminalisation. How that is not is not mentioned anywhere in the recommendations is, I think was gobsmacking to many people. And, whilst I want to be positive about some outcomes that, that have been listed, I totally support them, and I remain optimistic that things can change. But I also remain optimistic that it's not too late. So that's the report. That's great. How about we actually now go in and talk to some of the people that are going to be really, truly harmed and have a higher rate of death if we don't do something different.
Great. Thanks, Alison.
I think, Rob, your framing of this was really interesting, of, governments that are a bit interested in this space but maybe not enthusiastically making it yet their first priority. And I wonder how we continue to build on what I think is some goodwill and some interest here to make this more impactful and a higher priority. I think this is a really interesting space. I think the Australian public are completely inconsistent around this issue. So I think, why have we got to pill testing? Because actually it kind of makes sense to a whole lot of people. Yeah? Actually, I think the level of public support in pill testing is very high. And that's interesting that actually we've now got to that point where that just kind of feels like common sense. But other things of the spaces in which we're working don't make common sense to the public here. And so the broader politics that we're dealing with is actually quite incoherent. I kind of think that's a bit of a reality, but the opportunity for us, I think, is to keep on finding concrete parts of the work that we all know needs to be done to explain it to the broader public, to continue to make this less scary for politicians to be doing the right thing. I think we all know there are some, maybe not everybody, there's a whole lot of people in our parliaments who privately would probably want to go some places who can't see the political path. Yeah? Part of our job as a sector is how do I think we make it easier for our friends to do the things they kind of want to do, but kind of can't get through. Yeah, can't get through the politics, can't get through the public debate. I guess my hope would be if we're in a place where now we've got a bit of interest in making some progress, and to be honest, I don't think we've had much interest in making progress for the last decade. We've had a lot of interest in justice and not a lot in health. Yeah? If we read, it's exciting to me, this is my optimism, I'm kind of with Alison on pretty much everything, I think. It's exciting to me that first recommendation, I know it's a small thing, but is framing that the next 10-year strategy is having a goal of harm minimisation. That's actually going back to, let's treat drug policy as a health issue, not as a justice issue. Yeah, we made progress when that was possible back in the kind of 80s and 90s. That was the last period where a whole lot of work would be possible when we started from that point. I think our role as a sector is to find out, hang on, what's the really concrete things? What's the next steps? What's the things, the problems that can be progressed, maybe not completely solved, on the next step of a journey for trying to do better drug policy, and then how do we make that, like trade off the areas where we have actually, I think, quite a lot of goodwill from the broader Australian public who don't really want to think about this a lot. They want to think about it a bit. They will respond better, I think, hearing human stories and really practical action. And you know what? We've got heaps of those. You know, that's why most people support MSP. That's why people are now supporting pill testing. That's why people would support people are able to get appropriate support as they get it. Now, I know that's steps along the way. I reckon there's ways to play that narrative in some of the justice issues as well. That it's kind of pointless spending all of this money on certain kinds of policing for no result. How about we set some models up which actually help people get on a better place in their lives? That's tricky, and I reckon that's going to feel kind of like compromising along the way as well. But I reckon we have got a window, and we really should find some ways to work together to work out how it is we do that with government. My only other point would be what I really hope is that as we do that strategy, we genuinely do that in a partnership between government, between services, between clinicians and professors, and most importantly, people with lived experience. Yeah, so if this works out as a government strategy rolled out and just issued to the public, I don't think we'll make the progress that we need to. If all of us are working together and having some of those tricky debates about, what do we move on first and in what order and how do we resource it, we've got a real chance of success.
Right. Thanks, Michael.
In preparation for this panel, I had a good look at the issues paper, which isn't, your lightest reading, and I was struck. So the two recommendations: one, do it again, do it more, and write it up, and the other was do all the things in the submissions.
Yeah.
Okay, great. But how many inquiries, commissions, reports, summits have we had? How many more views do you need put forward? Can we just not move on with some recommendations actually getting finished? But for those who haven't done the deep dive into the content, there's beautiful things in there. And I think it might not all be there or go far enough, but I think if we all had faith that would come off, we'd be really excited. Some of the stuff that's acknowledged around silos and the need to work across sectors, not just within the AOD sector, but to address the social determinants of health, some of the stuff around short-term contracts and data and burdens that we face every day, around stigma, addressing things through a health lens and with harm minimisation. There's some great stuff there, and no wonder, because a lot of it came from a lot of us and from other wonderful people in the community. But I think if we had some runs on the board and we'd seen some progress and we had some political buy-in, we might all feel a lot more buoyed by seeing some of that good stuff written down yet again.
Thanks, Stephanie. And final comments from Maureen or Craig?
So much to say. I was one or two drug users at the 99 summit, and you made me so depressed because, the recommendations are the same. They're the same now as from the 99 summit. I read them, they're the same. So it doesn't feel like much has changed. And in the early days, NSP was not supported by the community. I remember Michael Kirby, everyone hated us, So sometimes you really got to just stick it out there, I suppose.
But we're there now.
Yeah, true. And the other thing is, I suppose I wanted to tell a quick story because I think this history isn't well known, but as far as I'm concerned, Newer is responsible for getting the Sydney MC Cup. And as per usual, drug users don't get acknowledged for the work they did. It was our policy officer in Newer called Rod Bennison. He was the guy who went and spoke to politicians, and like you said, talking to politicians. We did this before the drug summit in '99 was ever announced. He met with Ian Cohen, who was the Greens member of the Legislative Council at the time, and they went and spoke to all the other politicians about NSPs in prisons, heroin trials, and the safe injecting facility in Sydney. All that pre-groundwork was done before the summit was ever announced. And I've been to so many conferences like this where people go, wasn't it amazing the way the politicians voted for a safe injecting facility? Why did they do that? Isn't it amazing? It's like, Rod Bennison, our policy officer, he went and did all that groundwork. And I feel like that's why it was voted for. And a lot of that advocacy work does get kind of forgotten, I think. But it's so important to go out, like in America they do town halls. I'd love to do those in Australia, just go and talk to community. What are your issues? And that's how you get people on board, I suppose, for change and for supporting this stuff. So, yeah, more of it, more grassroots groundwork, and I think we can get there.
Thanks, Maureen. Okay, we need to wrap up now. I've been given the sign that it's time for us to wrap up, but please thank our panel members for sharing their views and experiences.